Welcome to This Week in Pulmonary. This week we're covering 10 notable papers spanning COPD, from beta blocker safety to CT-based case finding and risk prediction, sleep apnea epidemiology, critical care monitoring and ventilator liberation, and finally, interstitial and pediatric airway disease. Let's dive in. We'll start with the question that comes up in almost every clinic. Should a patient with COPD and cardiovascular disease be on a beta blocker? In chest, Suissa and colleagues used the United Kingdom Clinical Practice Research Data Link to build a cohort of nearly 12,000 beta blocker initiators with both COPD and cardiovascular disease, each matched to a non-user on time, propensity score, and cardiac indication in a prevalent new user design intended to emulate a randomized trial. Overall, starting a beta blocker was associated with roughly a 12% lower risk of death. But the benefit was entirely concentrated where you would expect it from cardiology. About a 23% mortality reduction in heart failure and a 16% reduction in ischemic heart disease, with no signal at all in atrial fibrillation, and if anything, a neutral to unfavorable point estimate in hypertension. The more provocative finding is the interaction with inhaled therapy. Among patients concurrently taking a long-acting beta agonist, the mortality benefit essentially disappeared, while among those not on a long-acting beta agonist mortality was about 20% lower, and that interaction was statistically significant and driven by the ischemic heart disease group. This is observational and residual confounding cannot be excluded, but the practical message is clear enough. Do not withhold beta blockers from COPD patients with heart failure or ischemic disease. Be much less enthusiastic when the only indication is hypertension or rate control in atrial fibrillation, and recognize that pharmacological antagonism between inhaled beta agonists and systemic beta blockade may be clinically real rather than theoretical. Staying with COPD, two papers tackle detection and risk stratification. Also in chest, Abdo and colleagues asked whether the low-dose CT scans already being done for lung cancer screening can be mined to find undiagnosed COPD. Among just over 5,000 screening participants who underwent spirometry, more than 1 in 5 had previously undiagnosed airflow obstruction, a prevalence of 22%, which is a striking amount of missed disease. Using emphysema extent alone at an optimized threshold of about 5% performed only moderately, with an area under the curve of 0.69 and a positive predictive value of 44%, and it would have sent 41% of the cohort for confirmatory spirometry. Adding artificial intelligence-derived airway wall thickness and airway branch count together with smoking history and dyspnea lifted the area under the curve to 0.83 and the positive predictive value to 59%, while reducing referrals for spirometry to about a third of participants. So if your institution runs a screening program, the structured CT report plus 2 simple clinical questions is a more efficient triage tool than emphysema score alone. Then, in respiratory medicine, Ju and colleagues examined post-bronchodilator mid-expiratory flow, FEF, 25 to 75, in 830 patients from the Korean KO-COSS cohort, followed for 3 years. Patients in the lowest quartile had a far heavier exacerbation burden, with 81% having at least one moderate to severe exacerbation versus 54% in the highest quartile, and mean cumulative exacerbations rising from 2 to nearly 6. Crucially, though, that association survived adjustment for forced vital capacity, but vanished completely once forced expiratory volume in 1 second was added to the model. The honest conclusion is that this index is a marker of overall physiological impairment, not an independent small airway-specific predictor, so there is no case for reporting it as a separate risk flag beyond what the FEV1 already tells you. Rounding out COPD in the International Journal of Chronic Obstructive Pulmonary Disease, Farhat and colleagues developed and internally validated a prognostic model for in-hospital death among 392 patients admitted to intensive care with an acute COPD exacerbation, of whom roughly a quarter died. 6 routinely available admission variables: age, male sex, urea, albumin, C-reactive protein, and the Charlson Comorbidity Index produced an area under the curve of about 0.90, outperforming Apache 2 at 0.81, with good calibration and stability across 1,000 bootstrap resamples. It is retrospective, single-center, and lacks external validation or comparison with established COPD-specific scores, so treat this as promising rather than deployable. Turning to sleep, 2 papers this week land in respiratory medicine, and both should be read with your epidemiology hat firmly on. Azarian and colleagues used natural language processing to extract apnea-hypopnea index values from Veterans Health Administration records across more than 146,000 veterans referred for sleep studies. Unadjusted, severe sleep apnea was associated with higher mortality in both sexes, but after full adjustment, the direction reversed, with severe apnea associated with roughly 40% lower adjusted odds of death in women and 44% lower in men. The apparent protective effect was largest in older adults, where adjusted odds of death were around 70% lower in women. Nobody should conclude that severe apnea prolongs life. This is much more plausibly a signal of referral, diagnosis, and treatment bias. Patients who get diagnosed are engaged with the health system and likely receive therapy, plus the collider effects of adjusting for obesity and cardiometabolic comorbidity in a referred population. It is a useful reminder of how badly clinically diagnosed cohorts can mislead. Alongside it, Huang and colleagues followed more than 2,600 adults aged 60 and over from the Guangzhou Heart Study, all free of sleep apnea at baseline, and identified 379 new cases over a median of about 31 months. Of 6 inflammation-related biomarkers tested, only serum bilirubin was associated with incident apnea, roughly a 40% increase in risk, comparing the highest with the lowest quartile, somewhat stronger in women, and in those over 68, while C-reactive protein was associated with risk in men only. The 4 other markers, including neutrophil to lymphocyte ratio and the systemic immune inflammation index, showed no association. Since outcomes were ascertained by Berlin questionnaire rather than polysomnography, this is hypothesis-generating and should not change any testing pathway. On the critical care side, Baptistella and colleagues offer a narrative synthesis in CHEST proposing what they call a 3S framework for ventilator liberation: screening, separating, and securing. Screening covers sedation management, preservation of limb and respiratory muscle strength and cardiac function, and the transition from controlled to partial support. Separating covers readiness assessment, the spontaneous breathing trial itself, and the extubation risk decision. Securing covers post-extubation management to prevent recurrent respiratory failure. There is no new outcome data here, but as a way to structure a fragmented and highly variable process, and as a teaching scaffold for trainees, it is worth reading. Complementing that, Cacelli and colleagues in respiratory medicine tested transcutaneous capnometry against arterial blood gas in 100 patients with acute respiratory failure, sampling at baseline and again up to 12 hours later. Correlation was excellent at baseline, but degraded meaningfully by the later time point, and just under a quarter of paired values fell outside the clinically acceptable range, though the device underestimated arterial carbon dioxide in only 5 cases. Deviations clustered significantly in patients with circulatory impairment, and every clinically relevant discrepancy traced back to a technical error that a trained operator would have caught. Use transcutaneous carbon dioxide for trends, not absolute decisions, and distrust it in the shocked or poorly perfused patient. Finally, 2 papers on chronic parenchymal and airway disease. Patron and colleagues report a multi-center retrospective cohort in respiratory medicine of 58 patients with connective tissue disease-associated interstitial lung disease who had objectively progressed a mean forced vital capacity decline of nearly 16% over a standardized 6-month window, despite mycophenolate or cyclophosphamide. After rituximab, mean forced vital capacity rose by close to 5% early and by nearly 7% at 12 months, with a concordant improvement in diffusing capacity and no toxicity leading to permanent discontinuation. Improvement was descriptively more frequent in inflammatory predominant phenotypes and in those with better preserved baseline lung volumes. There is no control group, and regression to the mean after a steep decline is a genuine concern, but this supports rituximab as rescue therapy chosen earlier rather than an end-stage fibrosis. And in a whole available population cohort from 4 remote Western Australian communities, Laird and colleagues rescreened 191 Indigenous children 6 years after initial respiratory screening. 17% had a chronic respiratory condition with significantly lower forced expiratory volume and forced vital capacity Z-scores than healthy peers. Among children who had chronic wet cough at baseline, 35% had chronic suppurative lung disease, or bronchiectasis, 6 years later, a risk close to 30 times higher than in children without wet cough, and prior hospitalization for acute lower respiratory infection also carried a markedly elevated risk. Chronic wet cough in a young child is not a benign symptom to observe. If you only have time for one paper this week, make it the chest beta blocker study from Suissa and colleagues. It directly answers a decision you make repeatedly, it sharpens the answer by cardiac indication, and the interaction with long-acting beta agonist therapy is a genuinely new consideration for how you co-prescribe. Here are the key takeaways from this week in pulmonary. First, in COPD with cardiovascular disease, beta blockers reduce mortality in heart failure and ischemic heart disease, but not in atrial fibrillation or hypertension, and concurrent long-acting beta agonist use may blunt that benefit. Second, if you have a lung cancer screening program, combining CT airway biomarkers with smoking history and dyspnea is a far more efficient way to select who needs spirometry than emphysema extent alone. And remember that more than 1 in 5 screening participants have undiagnosed COPD. Third, mid-expiratory flow adds nothing to EV1 for predicting exacerbations. Fourth, the apparent mortality benefit of severe sleep apnea in the veterans cohort is a lesson in referral and adjustment bias, not a clinical finding. Fifth, use transcutaneous capnometry for trends only and be skeptical in circulatory failure. And finally, chronic wet cough in early childhood is a strong predictor of later bronchiectasis and warrants active management, not watchful waiting. That's your roundup for this week in pulmonary. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And a quick rating on Apple Podcasts or Spotify helps other physicians discover the show. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.